Hello.
1 minute. Where are the others? Where are the others? What, Venkat Reddy? Where are your colleagues? Where is Madhusudan? Pratyusha, Kirti? Okay, when it's ready, you tell me. Who's the person there? Those in the third bench and fourth bench, come forward. Good afternoon. We welcome you all to the second webcast PG session from our hospital, KKCTH, today. The agenda for the session will consist of 1, and if time permits, 2 cases which will be discussed by 2 of our senior consultants, Dr. Lalita Janagraman and Dr. Janani Shankar. We did it last month and it was supposed to have been held 2 weeks back. It has been postponed today, and Meanwhile, I am very happy to welcome our Medical Director, Dr. Bala Ramachandran. I request him to introduce the beginning of this session, and then we'll proceed with the case discussion. Over to Dr. Bala Ramachandran.
Good afternoon, everybody. I'm Dr. Ramachandran, as Dr. Balasubramaniam already mentioned, and we're all very happy that so many of you are joining us across the country in this wonderful idea of a webcast from various specialist centers, which will be of benefit to everybody. We have a very enthusiastic and experienced team of teachers, Dr. Janani Shankar and Dr. Lalita Janikaraman, who have between the two of them more than 45 years of teaching experience. So I think it is something which will be of use to everybody, and I look forward to the interaction after this. And once again, welcome and thank you for joining us.
As I said earlier, the first case that is to be discussed will be discussed by Dr. Vindhya, DNB graduate from KKCTH. Over to Dr. Vindhya and Dr. Lalita and Dr. Janani.
Good afternoon, one and all. I am presenting a child of 5 years old. Tanvika is a school-going 5-year-old female child. They are hailing from Chennai, whose reliability is good, with complaints of fever for past 2 months duration and cough for past 5 days duration. Child was apparently well 2 months back when noticed to have fever, which was there for past 2 months. It was documented 101 to 103 degree Fahrenheit, was intermittent in nature. Initially it was present once in 2 to 3 days, but for the past 15 days it has been a continuous fever, around 2 to 3 spikes per day, and sometimes it is associated with the chills and rigor. In between the fever, child has been active and she has been attending her school as before. The cough for the past 5 days duration, it is wet in nature. There is sputum production associated with sputum production, which is a minimal amount. It is white in color, mucoid, not foul smelling. There is no blood in sputum. The cough is not associated with any postural variation, and it doesn't aggravate on lying down. It is not associated with any breathlessness or rhinorrhea or snoring. There is no history of any bluish discoloration of the extremity of the lips. There is no history of any reduced urine output with swelling of feet or any increased precordial activity. Her sleep pattern has been normal. The cough is not disturbing her sleep. Her appetite during this period has been normal, but there has been a documented weight loss of 500 grams. 1 month prior, her weight was around 14.1 kg, and during hospitalization, her weight is 13.6 kg. So there is 500 gram weight loss for the past 1 month duration. Her urine, she is voiding urine well. There is no burning micturition, and her stools are normal. There is no history of diarrhea. There is no history of any pallor or abdominal distension or rash or jaundice noted. There is no history of any joint pain or joint swelling. there is no history of contact with the open case of tuberculosis during the past 2 years. There is no history of contact with the pets and no history of any recent travel and no history of any raw milk ingestion. And she has been growing normally and she has been gaining adequate weight. For the above complaints, child was initially investigated as outpatient basis. She underwent some blood investigations and she was treated with some medication not available. But since her symptoms persisted, she was hospitalized 4 days back. And after hospitalization, she continues to have, and her cough has increased. Cough has increased, but there is no fast breathing, and she is not requiring any oxygen. She has underwent some blood investigation. Chest X-ray has been done, and she has underwent bone marrow aspiration, and she is being treated with IV medications.
This child, no, which is 2 months duration.
Yes, ma'am.
And it is continuous. So
For the 15 days it is continuous. Prior to that it was intermittent. It was there once in 2 to 3 days.
Okay.
But now 15 days she is having daily fever.
Can you just can any one of you tell what do you mean by continuous fever? She used 2-3 terms, continuous, intermittent. So
Intermittent fever is, there will be fever, but fever will touch the baseline, madam. Continuous fever will be present throughout, and it will not touch the baseline, and the temperature difference will be less than 2 degrees Celsius.
what is remittent?
Remittent fever, it is the temperature will be more than 2 degrees Celsius.
Yeah. And there also it doesn't touch
To the baseline.
normal. Okay. Now what type of fever is Bell-Epstein?
Bell-Epstein fever, it is mostly seen in Hodgkin's lymphoma. In between, that is after they will have a period of afebrile period of 3 to 4 days, then again she will get a fever.
Okay. So it's a relapsing fever.
Yeah.
Call it that way. And one more thing in your history, you said a weight loss of 500 grams in 1 month, right? You think that is significant?
As per definition, significant weight loss is loss of weight 5% over a period of 3 months duration. So it doesn't fit into that, but still her appetite being normal and having weight loss, I think it is significant. She was admitted once 8 months back in February for fever, which was there for 7 days duration. She was hospitalized and investigated, said to have typhoid fever, and was hospitalized for 7 days. In the month of May, that is 5 months back, she had a cough for 10 days duration, but the cough was not associated with any fast breathing, was not associated with fever, and there was no sputum production. She was evaluated with chest X-ray, and she was said to be normal, and was treated with some nebulization and anti-allergic medications. And after that, she has been normal.
She said no history of contact. Can somebody else tell what do you mean by contact?
Contact is contact with an open case of tuberculosis who has been started on treatment or completed treatment within the last 2 years period within the household, not more than 2 years, should be within the 2 year period. Adult.
Okay, open case. She can summarize the history. Why don't you summarize your history? There's nothing else in the past history. Any relevant family history?
No, madam. She is born of non-consanguineous parents, and she is the first child. She has a younger sibling who is a boy who is 2 years old, and he is healthy.
So summarize your clinic history.
Respiratory system. Tanvika is a 5-year-old school-going female child. Was apparently well 2 months back. Brought with fever for 2 months duration, which is now being continuous for the past 15 days. Associated with the acute onset of cough, with the history of no loss of appetite, but maybe a loss of weight. I would like to think in terms of infective etiology, chronic infections.
What type of infections?
Bacteria, still tuberculosis, or viral etiology, Epstein-Barr virus. And weight loss, long fever, could be acquired immunodeficiency.
Okay. Now coming to the history of cough, little more about cough. Which condition do you think cough is more prominent? Which part of the lung gets involved, cough is more prominent?
Airway and
or a resolving parenchyma etiology. So this child had an acute onset of cough last 1 week or 10 days?
5 days.
Last 5 days. And the fever has been there for the last 2 weeks.
2 months.
2 months. 2 months on and off she's been well in between. So you cannot, I don't know, I'm really not able to give that much of importance to that fever of 2 months. Maybe 15 days is more significant. This 2 months on and off, we do not know exactly how long she's been, how many days she really had fever, documented fever, and in between she's been afebrile, which means she's responded to some antibiotics or that she has received in between. So just take 15 days fever and cough of acute onset cough. Then can you narrow down your differential diagnosis?
In school-going age with fever, cough.
Leave alone the weight loss. Weight loss, I would even say that the weighing machine difference. 500 grams weight difference is not very, as Madam mentioned, I wouldn't put much importance to that. Just take the 15 days continuous fever, school-going child, previously well. I think once nebulized in the past. So she's probably an episodic wheezer. And this time the fever has been the significant. Did she have any chest discomfort or chest pain at the onset of the fever?
No, ma'am.
I think in the history, I think you should mention that. Because you're giving so much of importance to the cough and shortlisting your system to the respiratory system. So maybe you should add something more to the respiratory symptoms at the onset. Whether she had some pain, whether the cough was associated with some chest discomfort or chest pain. Initially it's usually a pleuritic pain. Later on, when there is a resolving, then they get the productive cough. So now can you shortlist your differential diagnosis? Anyone?
Mycoplasma.
Why do you want to talk about organisms?
It could be lower respiratory tract.
Can be still a community acquired pneumonia.
Yeah.
What prevents it from being a community acquired pneumonia? Then you talk about atypical pneumonia and all that comes only after your investigations or your findings. This is just based on the history. Fever of 2 weeks duration, high grade, continuous according to you, along with cough which has been productive, bringing out sputum, and probably she's hospitalized for the same, which means it's been more significant enough to warrant hospitalization. So I think community acquired pneumonia should be your, of course you can think of causes other than the usual community organisms like mycoplasma, tuberculosis and all as your second, third. So some pneumonia, probably parenchymal lung disease, probably community acquired pneumonia. That would be more, wouldn't agree with your acquired immune deficiency and all. Can you justify that?
And since the fever is prolonged, I am suspecting.
Okay.
And the fever has brought them to the hospital.
I guess since it is 2 months of fever from the history, you always think about infection, inflammation, malignancy, immunodeficiency disorders. So probably ruling out one by one. Probably she's put all that into her list.
Anything else the audience want to add? Any history she has omitted? That's what she said. 15 days she said documented continuous. That is what we are asking, whether it was really significant or not.
Once is one spike or one day or...
she said in between 2 to 3 days she never had fever.
How many days did the school loss in the last...
No, there has been no school loss. She's been at home for the past Diwali, and after Diwali they got hospitalized.
That means that
all
fever
the
was
2
not
months
very
child has been
significant.
going to school
Yeah.
and...
She says, mother says
Playing
that
normally.
when child gets spike in school, they will send her from school. Not many times, once or twice.
How was she in between fever? Means
She's been well. Her activity is good. Her appetite is good.
is there any noisy breathing?
No noisy breathing. I told there is no...
No, she mentioned all that. Negative history, she mentioned all that. She mentioned even the cardiac symptoms to rule out cardiac causes. So I think it's just a respiratory infection. Probably, I think the 2 months fever, we'll still wait and see whether she has more points in her examination to justify that. Go ahead with anything? Yeah, that's what. We are only thinking of some respiratory infection. Probably we are talking about community empyema, even more very sick child. It can be. Let us get some more information. With just history, you cannot talk about empyema. And unless she is told about chest discomfort or chest pain, one-sided chest pain or something, or something like that, if she had told, then you can talk about empyema. That's why I asked her why you did not mention about chest discomfort, chest pain, cough, after the cough getting some discomfort or pain, or initially she had some splinting of the chest while coughing. All that she did not mention. Little more details about the cough with the respiratory system. Yeah, one of you can bring the child. She can sit here. Which chair? In the chair. Amma. You can have her on your lap. Have her on your lap. Yeah, no. You come and sit. Have her on your lap. No, she knows English very well. You please put her on your lap. Make her sit on your lap. If she sits alone, she'll cry. Put her on your lap. Yes. Yeah.
On examination, child is...
You can come this way. You're standing behind the child and talking.
On examination, child is alert. She is acutely ill looking. There is curly hair noted, but mother is also having curly hair. She is wearing a mask. There is pallor. There is periorbital puffiness. Eyes are normal. Ears are normal. Nose, there is deviated septum to the right side, but there is pale mucosa and hypertrophy of the inferior turbinate. Oral cavity, there is angular stomatitis present, no glossitis, no thrush, no ulcers. Tonsillar fossa, tonsils are present, there is no follicles. Posterior pharyngeal wall is normal. Left posterior cervical lymph node is palpable, which is 0.5 cm, significant. Bilateral axillary lymph node, the largest node is 1 cm in diameter, with soft in consistency, non-tender, not matted. Skin over the lymph node is normal and it is mobile. And bilateral inguinal lymph nodes are palpable, with the largest node measuring 1.5 centimeters. It is firm in consistency, non-tender, mobile, not matted, and skin over the lymph node is normal. There is no epitrochlear lymph node or occipital lymph node palpable. But since there is significant axillary inguinal lymph node palpable. There is generalized lymphadenopathy, ma'am.
When do you say significant lymphadenopathy?
If any lymph node palpable more than 1 centimeter in axillary or inguinal, axillary or posterior cervical region, and more than 1.5 centimeter in inguinal region, and of any size in the epitrochlear or occipital node, it is significant.
And you said generalized lymphadenopathy. No?
When 2 or more incontiguous lymph nodes are enlarged, it is called as
non-contiguous.
Non-contiguous. There is BCG scar is present. There is manto present over the left forearm, and it is negative after 48 hours. There is no petechiae or purpura. There is no few hyperpigmented macule is present over both lower legs. It is present for past 2 years. Initially, it was associated with itching. It is mostly insect bite allergy. Joints, there is no joint pain or joint swelling. There is no sternal tenderness. There is a plaster mark over the both posterior iliac region, both sides, suggestive of bone marrow aspiration being done. And there is abdomen distension. Hernial orifices are normal, and no respiratory distress.
Did you mention very itching in the nails?
No, ma'am.
She's obviously tachypnic. Can you not make out that? Do you think it's because of just anxiety, or is she febrile?
She is not febrile, ma'am.
Fever irka? She fever, having fever now? Now does she have fever? She's obviously tachypnic. If from a distance we can make out that her respiratory rate will be anywhere between 40, more than 40 per minute. Okay. And did you mention about the gross puffiness of eyelids?
There is no pedal edema. Nails, there is no, there is pallor, there is no icterus cyanosis or clubbing.
You said there is gross pallor. So what else would you look in the nails?
Chylonychia, ma'am. There is no chylonychia.
Okay. Where all did you look for the pallor?
Pallor
Let somebody
over
else answer. I'm sure India will be able. Yeah. Some interaction from the
Palpebral conjunctiva, tongue, palms and soles, palmar creases and sole creases.
If the palmar crease is pale, what does it indicate?
Hemoglobin should be less than 7. It's not a guide, but
No,
a rough estimate.
Rough estimate. Yeah.
Go ahead.
examination of respiratory system on inspection. Anthropometry.
We were talking so much about weight loss in your history.
Her weight is 13.6 kg, which falls in less than 3rd centile according to WHO chart for appropriate age and sex. Her height is 1 or 2 centimeters, which is between 3rd and 15th centile. Her BMI is 13, which falls between 3rd and 15th centile. So it indicates there is acute malnutrition. Vitals, her pulse rate was 100 per minute, normal in volume, no specific character. It was felt equally in all peripheral pulses. Her respiratory rate, now she is tachypnic.
Then you mentioned that when you saw, she was not tachypnic. I do not know, probably she's resolving and having problems. Yeah.
Her respiratory rate is 40 per minute and thoracoabdominal type. Her blood pressure was 90/60 millimeters of mercury, which was measured in the left right upper limb in supine position. Respiratory system examination. On inspection, trachea appears to be in midline. Chest wall is symmetrical. Shape of the chest is normal. Skin over there is no scars, sinuses or distended veins. There is no chest noted, and chest movement appears normal. Now she is tachypnic. And back, there is no kyphosis or scoliosis. On palpation, trachea is in apical impulse on inspection could not be visualized. On palpation, trachea is in midline. Apical impulse is in the fifth intercostal space in the midclavicular line.
Can someone come and examine the respiratory system of this child? Lymph node palpation probably one of you can do. One of you can probably proper respiratory system examination. Pratyusha, come. Do the lymph node examination of this child. Just demonstrate lymph node examination. Don't make her cry.
Examination of lymph nodes consists of examination of lymph nodes from mainly cervical, axillary, inguinal and other groups like epitrochlear and supraclavicular lymph nodes. Cervical lymph nodes basically they are superficial and deep cervical lymph nodes. Horizontal group and vertical group of lymph nodes. The horizontal group of lymph nodes consists of submental.
Show the instead of theory, let us be practical. You leave it, she will tell.
Examination of submental lymph nodes should be done.
Can you career down? Yeah, fine. You show. Remove the mask, no? Mask remove cheyandi. For some time you remove it, doesn't matter. A sweet girl, no? Don't cry. Okay?
Submental lymph nodes have to be examined standing in front of the patient and then like this. Roll the fingers from the below the chin, and submandibular lymph nodes have to be palpated from the front, and then posterior group of cervical lymph nodes have to be palpated when we are standing in front. When we are palpating for anterior group of cervical lymph nodes, we need to stand behind the tail and then roll the fingers 1 to 2 or 2 to 3 fingers with pulp, not with the tip of the finger, and do not hurt the tail by inseminating the tip of the fingers, and roll over anterior border of the sternocleidomastoid. And also when we are deep cervical lymph nodes, we would like the patient to flex the minimal flexion of the neck and to bend the head towards the side where we are examining, and inseminate the fingers behind just opposite to the trapezius to palpate for the deep cervical lymph nodes. She has a posterior cervical lymph node on the left side, which is almost measuring 0.5 centimeter, which she has already described, which is soft in consistency, and the lymph node is mobile, which is non-tender and it is not matted, and the skin over the node is normal.
What are the other lymph nodes in this area which you have not yet mentioned? You mentioned submental, submandibular, anterior, posterior,
preauricular, postauricular and occipital lymph nodes. Axillary lymph nodes, and apical group, central group, anterior. I would like to sit.
Yeah.
You sit. Ideally, support.
Expose the axillary area, and then we will ask, when we are examining right axillary lymph nodes, to rest the child's hand on our right hand and palpate with our left hand. When to examine the right axillary lymph nodes, palpate with left hand.
What are the groups of nodes?
Apical lymph node, apical, anterior. Apical group has to be palpated deep in the axillary fossa. Anterior group should be palpated against the pectoralis major tendon, and the medial group to be palpated over the lateral chest wall, and the lateral group alone has to be examined by the right hand when you are examining for right axillary lymph nodes, right axillary lateral lymph nodes, which has to be palpated against the head of the humerus. Then posterior group of lymph node has to be on the posterior side.
Over. That's all.
Abduct and lift his hand, and then try to examine posteriorly over the posterior tendon.
Okay.
Against the posterior axillary fossa, wall of the posterior axillary fossa. An examination of inguinal lymph node has to be done in
epitrochlear.
Epitrochlear lymph node has to be examined with the flexion at elbow, and the fingers have to be passed from above downwards on the medial side of the humerus, just above the trochlea on the lower end of the.
And don't mistake the tendon for the epitrochlear node. Most of the time you keep rolling and tendon rolls easily. I think in this case that was done. There is no epitrochlear node. Okay.
And you all should also know the drainage area of whatever lymph nodes that you all have palpated.
Okay, I think we'll not trouble her with the respiratory system. We'll believe what Vindhya says.
Ask him to demonstrate.
Yeah, but she's really sick. It's true. You tell the respiratory system findings. At least the vocal fremitus, vocal resonance, chest movement. Any volunteers? Kirti? Chest movements, vocal resonance, vocal fremitus. So let it be more of a practical rather than theoretical. You eat the chocolate. Eat the chocolate. That's all over. One more the doctor will examine. That's all over. After this, I think we'll send her. Once you finish the respiratory system,
Examination, and then we'll send her.
Yeah. Doesn't matter, that's enough.
How do you look for inspection? Yeah. Foot end and head end.
If the child is sitting from front back.
Yeah. Ideally, you should make the child lie down.
Lie down.
Okay. And then
Inspect for chest movements from anteriorly. Chest is moving bilaterally, symmetrically, anteriorly. And from
the mask.
Posteriorly also, both the sides are moving equal. But there are chest retractions, lower 3 chest indrawings are present. And from sides, after lifting the child's hand, will inspect on each side separately. When the sides are moving, the side is moving. Now we should compare with the opposite side. Ideally, we should make the child sleep and look from the foot end and the head end of the child and inspect for the chest movements. Chest. First, put the hands on supraclavicular areas to look, compare for the movements of supraclavicular areas. Place the hands anteriorly to look for the movements of the anterior chest. Then object is called all the bilaterally such as moving symmetrically. And to demonstrate ideally to the level of the patient, బాగా శ్వాస పీల్చుకొని వదులుతావా? గట్టిగా ఊపిరి పీల్చుకొని వదులుతావా? Keep the fingers parallel, just approximating to the chest, but not. You should splint the chest. The hand should be touching the chest wall on the side, but you should not splint the chest to restrict the movements of the chest wall. And ask her to take in a deep breath and exhale. Kana getiga shwasa peelchukoni vadultava? Good, good, good.
How much should be the usual normal chest expansion in children?
2 to 3. On palpation, right side is moving lesser than the left side of the chest. Right side is moving lesser than the left side.
No, madam. Yeah.
Yeah, proceed with the rest of the examination.
On percussion in all the 9 areas, supraclavicular and infraclavicular, mammary, then infraaxillary and axillary and infraaxillary, and posteriorly suprascapular, interscapular, infrascapular. It was resonant both sides. And on auscultation, there was normal vesicular breath sounds which was heard in all these 9 areas. There was fine inspiratory crackles heard over the left infraaxillary and infrascapular area.
Not very convinced.
There is no reduced breath sounds.
Yeah, errantry seems to be equal.
Bronchial breathing.
Yeah, probably. It just keeps changing. Sometimes after a cough you can hear some crackles. Sometimes without a cough. Make a cough and then auscultate better.
And the abdomen examination, on inspection, abdomen is distended. Umbilicus is pushed down and it is mild transverse, but the contour is normal. Skin over the abdomen is normal. There is no sinus or scars, and all quadrants move with the respiration. There is no distended veins. Back is also normal except for the plaster mark which is present. And on palpation, it is not warm or tender. Liver is palpable 5 centimeters below the right costal margin in the mid-clavicular line. It is soft in consistency, smooth surface, sharp borders, round borders, and liver span is 9 centimeters. Left lobe of liver is not palpable. Spleen is palpable 3 centimeters below the left costal margin. It is soft in consistency, smooth surface, moves with the respiration. It is not tender. No free fluid in the abdomen noted. And on auscultation, there is no bruit heard. System examination, in the cardiovascular system, first and second heart sounds are heard. There is no murmur. Neurological system, she is normal.
Okay. Summarize your history and clinical facts.
Tanvika is a 5-year-old school-going child, previously well, now presented with 2 months of fever with acute onset of cough, and clinically there is she is undernourished. There is significant pallor with periorbital puffiness and tachypnic. with the left side crepitations over the left infra-axillary and infrascapular region with mild hepatosplenomegaly.
You mentioned generalized lymphadenopathy.
With generalized lymphadenopathy. But there is no significant rash or joint swelling or stem.
So what would you like to have your differential diagnosis at the end of complete examination? Would you like to change your diagnosis?
It could be still infection and it could be inflammatory also, madam.
Infections? What infections do you think of?
Bacterial, I think of maybe disseminated tuberculosis, or since fever and lymph nodes and pallor and mild hepatosplenomegaly is there, it could be Epstein-Barr virus. But only thing, fever is prolonged and respiratory signs are there, which could not be explained by this. Or it could be still immunodeficiency, acquired immunodeficiency, because it is multisystemic involvement. There is both respiratory and abdomen with pallor and lymph nodes. It could still be primary immunodeficiency, ma'am, but previously she had no significant issues in the past, and she's been, otherwise development is normal. And there is no, she is non-consanguineous parentage, there is no significant family history. So I think be acquired.
What do you think is the reason for such gross pallor in this child? You said she's new. Her appetite is well preserved, she's eating well, she's been a very well child who's been attending school, not missing school, unwell only for the last 2 weeks. Do you think it's nutritional anemia, or what is her diet history?
Diet history, she's on mixed diet. They gave chicken and fish once in a week, and she takes twice or thrice eggs in a week, and otherwise she takes morning idli and afternoon dal, rice. Her calorie intake was, expected calories 1400 kilocalorie, and she takes off 800 kilocalorie. There is a gap of 600 kilocalories, which comes to a deficit of 40%. Protein content is normal. Her expected protein content is 21 grams. It is normal.
You have mentioned a few differential diagnoses. Fever, striking pallor, generalized lymphadenopathy, what else would you like?
Malignancy.
Yeah, you should think of other things. What else? You are not able to justify your pallor, but the nutrition seems okay. What is the reason for anemia in this child? One mic. You have this mic. You keep one.
Maybe the chronic illness, fever, so there's no history suggestive of any blood loss, hemolysis or anything like
The
that.
history of blood
No
transfusion,
jaundice.
did you mention? Was she transfused in the past?
Okay. Or maybe some edema, but it's only facial edema.
Facial edema is because of pallor and anemia. They're asking how do you account for such severe pallor in this child? 1, 2, 3, you tell the causes. Yes.
And so she might be having a
Can be an underlying anemia which is made worse by the anemia of, complicated by the anemia of chronic infection, or an infiltrative disorder which has made the pallor become more prominent. So we do not know her baseline, what was her hemoglobin. Then what else would be your differential diagnosis? You're still sticking on to the respiratory system, or you want to change now? 3, your diagnosis was restricted to the respiratory system. Now do you still want to restrict yourself to the respiratory system, Or you want to make it as something more?
It could be infection, inflammation, or a malignancy. You have to evaluate.
So what is? You have to tell 1, 2, 3 what it is.
Ma'am, infection I still think because the fever and symptom, and the fever is not affecting her activity. She has been attending school and her appetite is good. But since there is other markers like there is pallor, there is lymph node, there is hepatosplenomegaly, there is cough, so I think it is a multisystemic disorder. So could be a disseminated tuberculosis, or it could be a inflammatory pathology.
Why not EBV as your first diagnosis?
EBV, but so much significant anemia and
why not? Can have.
And lung maybe infiltrates.
Can have secondary infection, bacterial infection. So it's a viral infection, no? It can have cough. You cannot. So I think first diagnosis should be your EBV. Then probably disseminated tuberculosis. Then you can go on to other infiltrative disorders. So how do you proceed to investigate this child? We'll ask the audience to interact. Vidya's. Is the mic on?
Complete hemogram, peripheral smear. Complete hemogram to look for the degree of anemia and to look for the other cell lines are affected or not. Peripheral smear to look at the morphology of RBCs and if there are
what would be the RBC morphology in anemia of chronic infection?
Normocytic, normochromic, or macrocytic.
One at a time. No chorus answers.
Normocytic, normochromic.
And how do you differentiate it from iron deficiency anemia? Other microcytic, fine. Sometimes it is associated with iron deficiency anemia. Suppose this child had an underlying iron deficiency anemia plus a chronic infection. Then how do you differentiate?
We have to look at the other marker, serum ferritin, TIBC.
What is one more test which will help you to further clear cut say that it is only anemia of chronic infection or only iron deficiency anemia?
Other markers, MCV, MCHC, and serum ferritin, TIBC. TIBC is high.
Serum ferritin, what will happen in iron deficiency?
It will decrease.
In chronic infection?
It may be normal or sometimes it may be high.
Soluble transferrin receptor. That is one thing that will help you to differentiate. That will be lower in infections and it will be higher in iron deficiency. So that's another thing. The ratio of ferritin versus soluble transferrin receptor is one more marker that can differentiate. Clear. The next one. What other investigations?
And
what else will you look in the peripheral smear?
Atypical lymphocytes also, because infectious mononucleosis is one of the DD based on the history and examination. Then because we have to consider with lymphadenopathy and hepatosplenomegaly, tuberculosis has also to be considered. So Mando has to be done, and in Riles tube gastric juice has to be taken for ASB examination. If the child is not bringing out sputum.
What cells will be seen in the peripheral smear which will help you to say it's probably tuberculosis? I think I've told you in one of the classes. That is not. Some cells which will go up typically in tuberculosis. Monocytes. If you see more monocytes, if you see a lot of eosinophils, atypical lymphocytes, think of viral. You see more of neutrophils with toxic granulation, think of bacterial. You see a lot of monocytes, that points out. Normally monocytes they don't report in the peripheral smear, the differential count. Very rarely. They'll say monocytes 10%, 7%, think of. That's one indirect marker. I'm not saying for all children with tuberculosis it happens. It's one of the useful marker for you to probably suspect that this child has got tuberculosis.
You said Manto, no? Can one of you elaborate what is used for Manto and how do you do it? Because most of you send them to the lab.
RT21.
Next thing.
2 tubes of PPD should be
one TU is what we are using. 1, 2 and 5 can be used, but what we use is 1. Okay. Of what?
RT 20 Twin 80 RT PPD 23.
Okay. PPD RT 23 Twin 80.
Twin 80.
What is Twin 80? What is Twin 80? I know we all read this PPD RT 23 Twin 80. All of us know, but what is it? PPD. Now what is Twin 80?
Madam asked what is Twin 80. Don't try.
Twin 80 is just a detergent. Why is it added? Prevent it from getting absorbed onto the plastic or the glass. So that's why the Twin 80 is added to the PPD. When would you consider a manto as significant? When you use 1 TU?
Greater than
somebody else? Yeah.
Greater than 10 mm, which should be read after 48 to 72 hours.
Now suppose
it should be measured horizontally, and induration should be considered significant.
If you need to repeat a manto, how soon can you repeat?
8 weeks.
2, 4, 6, 8. What? If need be. Minimum is 2 weeks. Any contraindications where you shouldn't be giving a manto?
Suspected immunodeficiency, primary immunodeficiency.
It has this hypersensitivity, and then sometimes. And if you have given a live vaccine, like when you have measles, after recovery from measles, usually we don't give manto because it doesn't mount a response. Even after
exanthematous illness, avoid.
They say for at least about 2 to 4 weeks, there is no point in giving a manto. Okay, so manto, then what other investigations?
Chest X-ray. Can you show the chest X-ray of this child? Adler ka.
Okay.
We didn't bring the X-ray. That is better, no? Before that we can discuss the other things.
Okay, what other investigations for
fasting gastric aspirate? Will you do or not? Sputum, she is expectorating sputum.
IAP stain culture and as well as expert TB RIFA, the sample itself, sputum sample itself can be sent.
What do you mean by induced sputum? Someone else can answer. Behind.
Rahul.
You take when you do an induced sputum. Yes, saline itself can produce bronchospasm, and make sure that the child is kept in a room where no one else is there, and take all precautions. Whoever is there with the child, has to wear a mask. T20 mask has to be worn, and you should have the emesis bowl, and forcefully the child has to vomit in that, and that has to be sent for your AFB. Okay.
Madam said about fasting gastric juice for AFB. How do you do that? How do you collect?
And then we generally give overnight fasting, and in the morning, early morning, we introduce the nasogastric tube, and we collect the sample from that. We can if no sample is coming, we can give saline and then we can collect. If it is not possible, at least 4 hours of fasting is mandatory.
Ideally 8
It
hours.
can be done as a outpatient setting. Ideally.
What lubricant do you use?
Ligno.
They say as far as possible don't use any of the surgical lubricant because they themselves are bacteriostatic. Okay. So you can just moisten the thing into the mouth and then pass it. And it has to be sent immediately to the lab. I mean any of these samples, be it sputum, be it
ASB or GNS.
Okay, what else?
Okay, we are still talking about investigating for tuberculosis. What else would you like to do in this slide?
Bone marrow aspiration.
Not coming. They've gone to get the X-ray. We'll discuss the X-ray. You mentioned about infiltrative disorders. How are you going to rule out them?
Inflammatory markers, CRP and ESR we can do. Just if it is usually in inflammation, ESR and CRP will be elevated.
You also mentioned one other cause, no, as mycoplasma. So, would you like to send anything for that?
She was telling mycoplasma even in the history.
Yeah, that's what. In the history itself, you mentioned mycoplasma. So,
Cold agglutinin antibody titer.
Okay then.
EBV you don't want to confirm. You said EBV is your first diagnosis. Any other confirmatory test other than your smear showing atypical lymphocytes?
EBV virus capsid antigen. IgM. EBV VCA. And bone marrow to look if there is any blast cells.
What is this quantiferon? Someone told about quantiferon. What is the mechanism in which it acts? What is it?
Quantiferon gold, no? What is it? What kind of
Not quantiferon. Expert TB.
Expert
TB.
Expert TB. Nucleic acid amplification technique, ma'am. It is a very rapid test in which we get result within 2 hours.
What is the sensitivity and specificity?
Generally, specificity is good. It is around 98%, but sensitivity varies with the type of fluid we are sending. It is for restic gastric juice. It is around 65%.
Yeah. It varies depending upon whether it is
fluid.
Yeah, whether it is sputum. See, suppose the sputum is positive, smear as well as culture, then the sensitivity is very high. But if suppose the culture is negative, sputum is also negative, then your sensitivity also comes down to around 60-65%. I don't remember the exact one, but it comes down.
X-ray is come. Can you discuss the X-ray? Is there a lobby to discuss? No.
See, tell us the date when it was taken, I mean the interval between the two X-rays, and then describe both the X-rays.
This was taken in the month of May when she was investigated as OPD basis, and it's a plain chest X-ray of PA view, which is showing this is actually normal, madam. Trachea is in midline. There is some mild peribronchial infiltrates, but it is not that much significant. And this X-ray was taken during admission, 27th October, which is showing fluffy infiltrates which are organizing like a pneumonia, and there is also right middle lobe opacification, which is another pneumonia. So actually it is bilateral.
Your findings are more on the left side.
No? The trachea is in midline, there is no shift, no cardiomegaly.
So the X-ray is not giving us any more
Clues.
extra clues for the diagnosis.
No mediastinal widening is there. But radiologist felt because this child has presented with fever and acute onset of cough, sir thought it is and pneumonia school age group, he thought more of mycoplasma.
Would you like to do a lymph node biopsy on this child?
If he didn't get...
I mean, so far you haven't... okay, we can probably see what we have got. But if not, if we don't get any clue, would you like to do a lymph node biopsy? You don't have a significant lymphadenopathy to do. If need be, which... suppose you have axillary, inguinal, palpable. Which group would you prefer to do a biopsy?
Cervical. Easy to take.
Cervical. She's right. Yeah. Yeah. And would you prefer an FNAC or an excision biopsy?
Excision biopsy.
Yeah. Whenever possible, always plan an excision biopsy. If there is no facility, nobody to report your pathology, then maybe FNAC. Otherwise, it should always be an excision biopsy. Any idea what is Paul and Rochester classification? Indications for lymph node biopsy. Okay, there are a few things which are absolute indications when there is a lymphadenopathy to do a lymph node biopsy. Okay, one is size, more than 2 centimeters. Other one is it is persisting despite whatever treatment for more than 3 months, and a few more. It is there in archives. You can just go up and read.
Okay, finished all this investigations for tuberculosis. What else are the investigations that are left out for this child? You think urosepsis? Yeah.
And this may
we want
be
to rule
viral.
out other infections. Yes.
Abscess.
She was talking so much about acquired immune deficiency. You don't want any test to rule out HIV ELISA
and immunoglobulin
profile. That is very, very important in this child.
You asked for an ultrasound of lymph node. What are the things that specifically one should look for?
Capsular breach present, and differentiation into cortex and medulla.
The echogenicity, the vascularity, and also the short axis, the long axis, which is the ratio is important.
Any
calcification. What did you say? Caseation. Ultrasound.
Maybe alteration in
Histopathology.
echogenicity, it can say.
Yeah.
That's only a finding that usually seen macroscopically when they open up.
okay.
Macro? Microcephaly child. Yeah, you can bring while we discuss a little more about this case. So how do you intend to treat this child? What are the investigations of this child, other investigations? We saw the X-ray. What about the blood count, the hemoglobin? Shruti,
So we don't need the exact value, but if you can just give us a graph
what was the
idea
hemoglobin?
whether
That is
it
very important.
Yeah.
Was there a thrombocytopenia?
There was a thrombocytosis with leukocytosis, and she got mild anemia. So initially we thought of autoimmune disorder.
We don't want what you thought of. You just tell us the value.
What is the hemoglobin?
around 8 or 7, no, 6, sorry.
8,
6,
7,
no,
6.
6.
What is the WHO classification definition?
Less than 11. 5 to 10, 11.5.
So what was her blood counts? 32,500 or something, if I remember total count.
Yes, ma'am.
Now come on, someone tell me what are the causes of leukocytosis. You have not answered, please. The boy behind Venkat Reddy. In between Venkat Reddy and Rahul. You.
Infections that can give rise to leukocytosis. Mainly viral infections.
Viral?
Bacterial mainly. And
when you have a high grade fever, high blood counts, what will you think of? 3 or 4 conditions you just tell me. Infections, what are the infections?
What are the common infections?
Bacterial infections.
In bacterial infections, which are the common?
What are the 3 things that
Rahul was very concerned about that.
UTI.
Yes, urosepsis.
Urosepsis.
Abscesses anywhere, abscess, pneumonia,
meningitis.
These 4 things should come to your mind. This child had a high total count. So probably it's just an organizing pneumonia. To me it looks like that. And what happens to the hemoglobin and the platelet acute infection?
Platelet count can be increased because it's acute phase reactant, so it can increase in case of infections. And hemoglobin that can decrease.
What are the clues that you get that there is no bone marrow involvement in this child from your complete blood count? Thrombocytosis. That makes you think probably it's not a bone marrow involvement. Because on the other hand, a thrombocytopenia, even a 1.5 lakhs or 1.6 lakhs with a hemoglobin that is this low, with a high count, we get worried whether it is infiltration of the bone marrow. So this should make you think of some infection with a hypercytokinemia. Probably that's causing the thrombocytosis and the anemia. So what are the non-infectious or non-inflammatory causes of high count leukocytosis?
Defects can present with a hyperleukocyte count even in the absence of infection.
Yes. I am saying no infection, no inflammation.
Response, ma'am. Any stress, seizures, acutely fatigue, hypoxia.
Seizures, hypoxia, fall from a height, in acute severe wheeze, anything can lead to a high total count. So don't go by just by the counts. Interpret the entire thing, including the everything in this child. What was the MCV in this child? I'm not sure. What is the RDW? Not done. You're not interested in knowing whether this child had an iron deficiency anemia or only anemia of chronic infection. So that will help you. Whether it's normochromic, we already discussed all that. Okay.
What did the bone marrow for this child show? Because you said bone marrow was done.
So how do you intend managing this child? What is the child receiving right now?
Child is on antibiotics.
Treating like a community acquired pneumonia. Azithromycin and
child is on ceftriaxone.
Ceftriaxone and azithromycin.
Yeah, and the fevers are
settling down.
Yes.
And you have sent expert TB fasting
sputum. Her first AFP smear is negative, but we sent for AFB culture and expert TB. And in addition, we are waiting for her bone marrow smear
and I'm surprised to see such a huge liver and spleen in this child, which is not fitting in if it is not a tuberculosis. If it is a community acquired pneumonia, you cannot fix that. Probably you should do the immunoglobulin profile and the other markers.
Her immunoglobulin profile has been done. Her IgA and IgG levels are high, but otherwise no. M and E are normal.
M should be high, no, for her?
Yeah,
it's an acute infection. And she's not mounted an IgM response?
No.
Then you should probably opt for a flow and others.
Sometimes children who are otherwise perfectly well sometimes CGDs can present like this. Usually they say necrotizing pneumonia and all that, but they can present with
chronic granulomatous disease is one thing
that can present.
You can have granulomas in the liver, abscesses in the liver, because such a huge liver, we do not know. The ultrasound was normal.
Mild hepatosplenomegaly.
No abscesses.
No abscesses.
So that's one more
Left
thing.
lower lobe consolidation, minimal free fluid. Her NBT has been sent, still awaited.
Yeah, that's what. I think we should go in depth about the immunological workup, because you cannot pass it off as just community acquired pneumonia, because she already has a huge liver and spleen. If tuberculosis is going to come negative, the next thing and your bone marrow is going to be negative for a malignancy, then the next thing that you should think of is immunoglobulin. Detailed immunological workup, I think, go ahead and do the flow cytometry and the nitroblue-tetrazolium reduction test and so on.
What is the other test that you can do other than NBT for a chronic granulomatous disease? Dihydrorhodamine test. DHR.
Dihydrorhodamine. Okay, have you got the other case? Yeah, I think with this case, summarizing, I think Vindhya did a good job presenting, but remember, you cannot talk about pathological diagnosis or etiological diagnosis at the end of your history. She got carried away by the radiologist's impression, and she mentioned that in the differential diagnosis when she summarized the history. That is not correct. Not permitted in the exams. You cannot say mycoplasma pneumonia and all that. You can say
bacterial.
Viral or atypical pneumonia is permitted, but don't mention that as a first differential diagnosis. That is number one. Number two is any sick child, especially with a respiratory system involvement, very, very tricky. Child can have variable findings. Findings may vary from the time. That's why I usually give the case, ask you to present. If you see the case the day before and present the next day, things can change. The other thing is that one of the examiners may be an in-house examiner. So if they have seen the case previously and findings have changed, you can probably say, when I examined the case, these were the findings. I examined at this time and these were the findings. And crepitations were not heard when I heard. Same thing can happen in the exams. Make the child cough and examine again. You can tell that. Probably you ask the child to cough, and because this child has got a productive cough. So the findings can easily vary. Clear? So that is another thing. Differential diagnosis, again, infections, inflammation, infiltrative. So 1, 2, 3, 1, 2, 3. Clear? Whether community acquired what is the food? We are not able to hear. Clear. No clarity in visual nor in speech. Yeah, I think she mentioned. You speak in the mic. They're asking for the answers.
I mentioned there was the cough didn't have any postural variation, and there was no edema. There is periorbital puffiness, which I mentioned in the examination.
Leukemia could be one possibility, we already discussed. Should we say 1 TU or 2 TU in exam? I think
as per RNTCP, say 2 TU.
Yeah. Okay. We are not able to hear. We cannot help it.
We can't do anything.
Alembic people have to answer that query. What are the respiratory system cases kept for DNB exam? And how will you examine the chest, movement of the chest with respiration?
That we demonstrate.
Usually they keep pleural effusion, empyema, consolidation, or an open cavitatory tuberculosis.
Is one thing that is commonly kept. The patients will
Those are the ones usually kept. And if you go to the north, to centers like Mansi, lot of patients from Bihar and Haryana will come, so you may get open case of tuberculosis, cavitatory tuberculosis. So wear a mask. non-infective fevers, query vasculitis. Yeah, we already discussed about inflammatory diseases. What is the ideal time in which chest X-ray has to be repeated? Radiological clearance takes a longer time. So always wait at least a week.
We repeat chest X-rays. The child is not
improving or
worsening.
deteriorating. You do repeat an X-ray after 48 to 42 hours. Otherwise, don't repeat at least till 1 week. That's all.
Postural variation she mentioned.
Suddenly
Whether
stop.
CAP can go without complications for more than 2 weeks.
Can go on sometimes.
This child had also received treatment outside, no? So, quite
Can
possible.
go on. Partially treated. Yeah. Clear? Go down, please. Yeah. Okay.
No clarity.
Guntur, it's not seen, I think. Andhra, it's not seen. All the other places it's seen. Okay. Guntur, it suddenly stopped. Okay, fine. I think that we'll summarize and finish that case. We've answered the queries too. That was a fairly okay presentation, but little more firm on your findings and don't do this. Next case. Can you bring the next case? Who's going to describe this case? This is a spotter. Spotter. Come. Sleeping, huh? Kucho nearga petko, bidda. Can one of you please come and describe? I think we'll call someone from behind. Behind the people are all sleeping, I think. You get up and come. Yourself. Yes, please come.
No need for any history, just a spotter.
Just look at the child and describe. I think he's hiding the camera.
Here is a baby lying in the mother's lap who is not interested in the surroundings, not recognizing the stranger. And on a general examination, the baby looks obviously microcephaly, no stranger anxiety.
Describe more about the head.
Small head, microcephaly, hyperthyroidism present. Nasal bridge.
How's the forehead?
Forehead is receding forehead. Hyperthyroidism present. Nice. And nasal bridge is flat.
What is that movement? What is that movement that the child had now? Clonic movements of the lower limb.
Ears appears large, but not low set.
Okay. Anything else?
Pointed chin. Tooth are present.
How do you describe the tone of this child? On appearance, on inspection?
On appearance, child is moving the fingers.
The tone is high or increased or decreased looking at the child?
Tone has been increased in the lower limbs.
Okay. Any abnormal movements did you notice?
Abnormal movements, myoclonic jerk has been noticed on the right lower limb. As you know, there is no twisting or extrapyramidal movement.
Okay. Just demonstrate the DTRs and the tone and the DTRs of the lower limb. Can you get a knee hammer, please?
కొంచెం நேரம் பார்க்கணும் ஒன்றும் பண்ணணும் அதுலேயே இருக்காது கொஞ்சம்
How do you think the tone is?
Tone is spastic, ma'am.
Yes.
There is a craft knife spasticity.
Clonus, demonstrate clonus till you get the knee hammer. Amy? Aim లేదు. That it's not present here. Clonus is not present. Reflexes. Reflexes alone. Yeah, there is no clonus. Reflexes alone you demonstrate, then we'll discuss. Only the deep tendon reflexes. The knee jerk at least. Knee jerk and the plantar.
There is an exaggerated reflex.
Don't hold it there, no? Normally. You hold it there and do.
No.
Yes.
Exaggerated reflexes.
Okay, fine. So what do you think is this? They can actually just take them. Yeah, come here. Where are you going? Excuse me. What do you think is the impression at the end of a quick general examination and neurological examination?
Nervous system examination, the child was not interested in the surroundings, the various movements, cooing sounds or anything. So his higher functions are down. On observation, grossly the cranial nerves appears normal, except there is a strabismus present and mild squint. Otherwise, the child has no facial cranial.
What is the striking thing that you saw in this child?
Microcephalic.
You think it's primary or secondary by looking at the child?
Because the mother is having normal head.
She's not the mother. How do you know that she's the mother? Don't look at that and say, mother needs not. I mean, not always, no? Father also can have.
Having this receding forehead is there.
Yeah.
That gives a clue that it could be even primary.
Yeah. The receding forehead, very severe receding forehead, is usually seen in primary microcephaly. Okay.
Any less than -2 standard deviations. -3 standard deviations.
3 standard deviations.
-2 standard.
More than 2. Microcephaly is. So what are the other differences between primary and secondary microcephaly?
Primary microcephalic and genetic and chromosome. There will be abnormal faces noticed and there will be hypertelorisms, everything can be associated with the primary. And that could be even associated with the parental size of the head, and that can be correlated with them. Whereas acquired secondary microcephaly can be because of the either brain problem or because of the bone problem or
what is the commonest cause of secondary microcephaly?
There could be development, after development there will be insult to the brain which causes the brain not growing. That could be generally because of the infections or HIE.
Yeah, HIE. Tell in medical terms, yeah.
Hypoxic encephalopathy. And during the development of the brain, if the baby has been not provided with the nutrients, even that can cause PEM.
What happens in PEM? Head is usually
fed. Usually it's not affected.
Meningitis and encephalitis, because of the brain growth, will be affected. Whenever there is a large infarct as a shooting, that could be happening.
Yeah. intrauterine infections, cerebral malformations. There's so many causes of acquired microcephaly. Okay. How do you differentiate between the two? How do you confirm your diagnosis?
Next one, the history, physical examination mostly.
Yes.
And measurements, anthropometry. I will measure even the head with the length of the child. If the head is measuring according to the Dain's formula, length by 2 plus 9.5 plus or minus 2. If the head circumference is matching with the length, that shows that this is not a primary microcephaly. It is not a primary microcephaly. And that could be something unacquired. And I will correlate with either the history, is there any HIE that correlates with the CP, if there is an infection that correlates with the meningitis, if there is any no history with the chromosome that correlates with the chromosomal disorders, or else if there is any overriding of the research that goes with the craniostenosis.
What are the other features you expect in a child with intrauterine infections?
Other features will be, there will be blueberry muffin spots,
Blueberry muffins? Okay.
splenomegaly, and the cataract, and heart lesions.
Yes.
On fundus examination, chorioretinitis.
How do you counsel these parents?
I will first establish my diagnosis, and I will
This
correlate with
the secondary microcephaly.
this
Had perinatal hypoxia. So how do you counsel? How do you do counseling and prevent it in the next pregnancy?
I will explain them that the baby's brain has an insult at the time of the birth, so the baby brain has been growing very slowly, but the baby brain is growing. But to grow this to the level still more, your support is much needed, and I will advise them to go for physiotherapy, and this physiotherapy will prevent the baby from major difficulties in near future, and like contractures and that thing. And I will ask them, I will explain them that the baby growth will be very slow. For these things like feeding.
That is counseling. You are talking about talking to the diagnosis. You are asking how do you prevent it in future pregnancies.
In future pregnancies, I will first mother's spark screen has to be done. If there is any treatment possibility for any infectious causes, we will treat the mother. And if genetically, if I found any reason for this child, I will counsel them in the
to do a karyotyping
and regular antenatal checkers,
ultrasound,
and screening even at the time, ultrasonograms for regular features, and then the institutional delivery will be preferred.
Yes. Sure. Sure. I think should we close? Questions in this?
More new questions have come?
Not stopped. That's all. Yeah, they have. Yeah. And you summarize the management clearly. Management of the first child? First one or this one? No, not clear when to repeat Manto.
Manto can be repeated after 2 weeks.
Can you summarize the management clearly? I think the first child they are asking. Yeah. So treating the child as a community-acquired pneumonia with third generation cephalosporins and antibiotics to cover atypical organisms, awaiting the AFB reports and the bone marrow reports. Second line tests are pending based, and the child is improving, so they are waiting. Better to undress the child.
Ideal time in which X-ray to be repeated.
You already told.
We have already said. If there is no improvement with
other methods to elicit clonus, I think he mentioned. You showed 2 methods of. He demonstrated that. Probably in Andhra it's not very clear. Only Andhra people are asking a lot of doubts. Okay.
So, my friend. I'll call her.
Close. Okay. Thank you all. Thank you, Vindhya, and what's your name, Doctor? Shekhar, Kirti, and Pratyusha. I hope, a lot of your queries, it's more of a practical demonstration of and discussion about the differential diagnosis and management. I think The second case also we discussed more about the general physical examination and examination of the neurological system. So, good luck all of you. Thank you.
Thank you.